Welcome to this video tutorial on direct ophthalmoscopy. Today, we shall learn how to use the direct ophthalmoscope to examine the innermost layer of the eye, that's the retina. There are many other instruments that can be used to examine the retina. Ophthalmologists would prefer using the indirect ophthalmoscope or use condensing lenses doing a slit lamp biomicroscopy, and these provide a distinct advantage of having binocularity, thereby providing stereopsis, and also providing a larger field of vision. The direct ophthalmoscope is a much simpler instrument and a very valuable tool for general practitioners, physicians, medical students, and resident doctors. There may be many different types of direct ophthalmoscopes, but most of them work in a very similar fashion. So let us start. But before we begin, let us know our equipment. The direct ophthalmoscope. Almost all direct ophthalmoscopes would have a handle, which would have the electric supply or the batteries, some rechargeable, some single life ones, and the head of the ophthalmoscope. Important, always remember to check your equipment. It would have a rotatory switch to turn it on, and you could see and check that the equipment is functioning well. On the head of the ophthalmoscope, you would see that there is a lens dial, and this is the viewing piece. Here, if you would notice carefully, there are certain numbers, some in green, which actually indicate positive lenses, yellow indicating a neutral lens, and red indicating minus lenses. These are very helpful in counteracting or overcoming the refractive error either of the patient or the observer. There are also certain filters and aperture changes that can be done on the dial. If you would notice carefully here, this changes the aperture and can be used in patients with undilated or small pupil. Also, there are certain other modifications. There's a slit here and a green filter. In fact, a red free light that's very helpful in examining the retinal vasculature and small microaneurysms and hemorrhages. The room has to be dimly lit. You will get a better visualization of the retina in a dark room. However, for the purposes of this video, we will not be doing this. A better visualization is also possible when the patient's pupils have been dilated. The ideal agent and the most commonly used agent is tropicamide 1% eye drops, which effectively dilate the pupil in about 15 minutes, and the dilatation remains for about 2 hours. However, I must warn you, before you dilate the patient's pupil, make sure that the dilatation is not contraindicated. You have ruled out conditions like narrow angle glaucoma. Explained to the patient that following dilatation, there would be some blurring of vision for a few hours. Make sure that you tell him he will not be able to drive back home, so he has someone who is going to take him back home. Once your patient is here, remember to greet him, identify the patient, establish a good rapport, explain to the patient about the procedure after introducing yourself. Tell him that you will be using an equipment which is something like a microscope to examine the back of his eye. You will be shining a bright light into the eye, which may cause some discomfort, but it will not harm the eye in any way. Also, during the procedure, you will be dimming the lights, you will be getting very close to the patient. He or she may be uncomfortable about it. Make sure you have a chaperone. Also explain to the patient that if he or she is uncomfortable at any time, assure him that you will stop. Having explained to the patient the entire procedure, you may proceed. So let us see how we would be doing direct ophthalmoscopy. The first part of the examination is to perform a distant direct ophthalmoscopy. Place yourself at a distance of about an arm's length or 25 centimeters from the patient. Switch the equipment on and shine the light into the patient's eye. On distant direct ophthalmoscopy, when you are shining the light from a distance of about 25 centimeters through a dilated pupil, you will get a bright red reflex coming from the patient's pupil. This is the light that is reflected back from the patient's retina. Distant direct ophthalmoscopy allows you to evaluate the ocular media, all those tissues through which the light passes to reach the retina. Compare the red reflex on two sides. If there is an opacification, the red reflex would be altered. You would be able to diagnose the opacification is based on the principle of parallax. You might find an opacification in the cornea, in the lens, or vitreous opacities. Distant direct ophthalmoscopy also gives you the unique chance to grade vitreous opacification. Having compared the red reflex on the two eyes, now we move on to examining the right eye of the patient. Before you begin, ask the patient to look straight ahead at preferably at infinity or some point on the wall opposite. To examine the right eye of the patient, stand on the right side of the patient, hold the equipment in your right hand, and use your right eye. As you move closer, turn your equipment on, set the lens at a +10 lens, and as you would move closer, you would have focused on the cornea. Now move the lens dial slowly and move as close to the patient as possible. Now as I approach the patient from the temporal side, almost at an angle of about 45 degrees, the first structure that I see is the optic disc. Against an orange background, a well-defined circular pinkish yellow disc, from the center of which I see a set of 4 blood vessels arising. In the center is a depressed area called the optic cup. After I have examined the optic disc for the cup, the color, the contour, the margins, I now examine the retinal vasculature. Move in the supranasal quadrant to follow the retinal vessels. Come back, move in the infranasal quadrant to follow the vessels. Subsequently, follow the supratemporal vessels, and lastly, the infratemporal vessels. Along with the vessels, examine the retinal background. To examine the macula or the centermost portion of the retina, ask the patient to look into your light. Thank you. So this is what a normal disc would look like. You can identify clear disc margins and blood vessels emerging from the center of the cup, which is occupying about 1/3 area of the disc. We may move to the supranasal quadrant, come back, go down to the infranasal quadrant, then come back, examine the supratemporal quadrant of the vascular arcades, come back, and lastly examine the inferotemporal quadrant. Having examined the retinal vasculature and the retinal background, we would now examine the macula in the center. The area which appears to be darkly pigmented and devoid of blood vessels. The macula in the center of it is the foveal avascular zone, and the centermost point, the foveola. Having examined the right eye, we move on to the examination of the left eye. To examine the left eye, you need to move to the left side of the patient and hold the equipment in your left hand. Use your left eye. Mr. Hakim, could you please continue looking straight? I focus at the disc, examine the optic disc, then examine the retinal vessels in all four quadrants. Examine the background retina and finally examine the macula. Look into my light, please. Thank you. So let us revise what we actually saw. After we finished our distant direct ophthalmoscopy, the first structure that we came across was the optic disc. If this was our area of visualization, as we moved in from the temporal side, the first structure that we saw against an orange background was a well-defined pinkish yellow circular area, the optic disc. In the center of the optic disc was a relatively paler depressed area called the optic cup. From the center of the optic cup, we could see that there were 4 sets of blood vessels emerging, arteries and veins that were leading into 4 different quadrants of the retina. A set of artery and vein going each in the supranasal, inferonasal, supratemporal and inferotemporal quadrants. The disc was well defined. On the surface, we wanted to examine the contour. There were no abnormal excavation or elevation of the disc. The margins were quite clear and sharp. The color was pinkish yellow. We also identified a healthy area of neural tissue lying between the margin of the cup and the optic disc, known as the neuroretinal rim. While we were still examining the optic disc, we tried to see the number of small blood vessels present on the disc. We saw where these central vessels were emerging from or entering into the optic disc. While at the optic disc, having identified the cup and the disc, assess the cup-disc ratio. Normally, the cup would occupy about 1/3 area of the entire optic disc. And examine the peripapillary area for any abnormal pigmentation, atrophy, or hemorrhages. There could be a concentric or an annular area of atrophy in high myopes. While examining the optic disc, you might find that the optic disc margins are blurred, the cup is obliterated, you can hardly make out the cup, the surface is elevated, and there are peripapillary hemorrhages, all features suggestive of papilledema. You might find that the cup is enlarged, actually occupying the almost 90% of the disc area. The blood vessels have shifted onto the nasal side and the cup is no more pinkish yellow. The neuroretinal rim is almost absent, and this is characteristic of glaucomatous optic atrophy. There may be a disc which is well defined but pale in color, almost chalky white, suggestive of primary optic atrophy. After having examined the optic disc, we followed the retinal vasculature, the 4 vascular arcades. Assess the arteriovenous ratio, which is the ratio between the caliber of the arteries and the veins. In normal patients, it would be about 2:3. Examine the vessels for their color. Is there abnormal sheathing or abnormal reflex coming from the vessel wall? Also examine the perivascular area for the presence of some small outpouching that may cause small microaneurysms or abnormal arteriovenous communications or even frank neovascularization. You may also come across arteriovenous crossing defects. In patients with long-standing hypertension, there would be changes where the arteries cross over the veins. After examining the retinal 4 vascular arcades, we go on to examining the general retina or the background fundus. There may be some abnormal reflexes, or you may come across small hemorrhages, which are deeper hemorrhages, a dot or large blotch hemorrhages. There may be superficial hemorrhages, which are usually shaped like an arrow pointing towards the disc. We may have small, discrete yellow spots as hard exudates, or more fluffy cotton wool spots seen as soft exudates. They appear more whitish yellow in color. There may be abnormal pigmentation. For example, in patients with retinitis pigmentosa, you may find a circle of black bone corpuscle-like pigments all over the mid-periphery of the retina. You may, while examining the background retina, may see some elevations or abnormal masses in the retina. While we are examining the background retina, you might see some discrete yellow spots, the hard exudates, the arrow pointing to those, or more fluffy cotton wool soft exudates as indicated by the arrowhead. There may be abnormal new vessels or neovascularization seen as suggestive of proliferative diabetic retinopathy, or even a frank hemorrhage that is seen just in front of the retina, in between the space behind the vitreous and the retina, a pre-retinal or a subhyaloid hemorrhage. We see pigments typically looking like bone corpuscles scattered in the mid-periphery with arteriolar attenuation and a very pale, waxy appearing disc. A fundus picture suggestive of retinitis pigmentosa. The background may be full of superficial flame-shaped hemorrhages, as if a tomato has been splashed onto the retina, a characteristic finding of central retinal vein occlusion. Or the entire retina would be pale with a typical cherry red-like spot at the center of the macula, seen in patients with central retinal artery occlusions. Having assessed the color, texture of the background retina and identifying any abnormalities, we now move to the center part of the retina, the very important macula, an area of avascular zone In the center, you would find a very bright reflex arising from the centermost point of the macula called the foveal reflex. You may identify abnormalities like a macular hole or hemorrhages or exudates around the macula. While examining the macula, we may find hard exudates present in an almost circular manner scattered around the macular region, or there may be very characteristic abnormalities like those seen in heredomacular degenerations, the Best's disease or the Stargardt's disease. You will get the opportunity to further master this technique during our clinical skills session and during your posting in the wards. Happy learning!